Hello and welcome. This is the fourth talk of the resident series of webinar. Today we have a special speaker for us who is a much lauded researcher in the field of movement disorders, Professor Yasukazu Kajita. He is from the Nagoya Medical Center. And today, on behalf of Professor Yoko Kato, the president of ACNS, and my co-host Dr. Liu, I welcome all the attendees as well as Professor Kajita. Professor Kajita, you may please start your.
Okay, so I'd like to thank you for giving me the chance to speak here today. My name is Yasukazu Kajita, and I work as a neurosurgeon at the National Hospital Organization, the Nagoya Medical Center in Japan. I specialize in the functional neurosurgery. Now I will talk about the deep brain stimulation for movement disorders. Okay. Today's topic is what is DBS? Indication and patient selection for DBS, surgical procedures, and long-term outcome. Yeah, what is DBS? The DBS surgery requires the fundamental understanding of the neural circuit underlying the pathophysiology or surgical targeting and intervention. The cortex and trans and basal ganglia loop are composed of at least 5 parallel functionally segregated neural circuits, channeling information between basal ganglia and the cortex via the trans. The 5 principal loops are the motor, the oculomotor, the dorsolateral prefrontal, the anterior cingulate, and the lateral orbitofrontal. So based on this model, neurosurgical intervention for Parkinson's disease and other psychiatric disorders have been developed. Next, so I'll mention the history of deep brain stimulation. The early surgical treatment for Parkinson's disease focused on relieving tremors. Corticotomy or ligation of perforating artery of the brain improved tremor, however, resulted in the paralysis of the patient. So the stereotactic system was introduced by Clark and Hosley, and Spiegel and Wicks, the first used to ablate the dorsomedial trams to relieve tremor in 1949. So following the successful introduction of levodopa therapy for Parkinson's disease in 1967, this ablative procedure was gone. However, levodopa therapy had a motor complication, and pyridotomy for medical refractory Parkinson's disease started again in 1992. But bilateral regioning caused dysarthria by 40 to 50%, very high percentage. In the case with the Parkinson's disease, it is necessary to be regioning on both sides. Therefore, it is a big problem. Yeah, Berry found that high-frequency stimulation has a similar effect to the regioning, and that the high-frequency stimulation of the VIM stopped the tremor in 1987. And in 1987, Schlegfeld demonstrated the beneficial effect of the high frequency of stimulation of the GPI. In 1993, Benabi has shown that the STN stimulation has a better effect of Parkinson's disease symptom, So DBS system has a reversible and adjustable advantage compared with the reasoning. And also the appropriate intensity, I mean the not strong one, this stimulation does not induce this arrhythmia. DBS therapy uses a surgically implanted medical device similar to a cardiac pacemaker to deliver carefully controlled electrical stimulation to precisely targeted area in the brain. So DBS system has a small battery operated device called an implantable pulse generator, so-called IPG, and tiny electrodes. So this X-ray image shows the DBS electrode implanted in the bilateral subthalamic nucleus and on IPG in the subcutaneous bilateral chest. The IPG has a rechargeable or non-rechargeable IPG. And in the non-rechargeable battery, the battery can be used for 4 to 5 years. Theoretically, so DBS works because the high-frequency electrical impulse block abnormal nerve signal in movement disorders. The clinician programmer is used to adjust the stimulation programming to best control the individual symptoms while minimizing side effects. Now I'd like to talk about indication of DBS. Yeah, the story that this is a busy slide, but the DBS is now a well-established surgical option for patients with medically refractory movement disorders with over 1,000 million patients implanted worldwide and in nearly 30 years. DBS of tremors was first approved by the FDA in the United States for tremors in 1997. Subsequently, DBS of STN and GBI for Parkinson's disease was approved by the FDA in 2002 and 2003, respectively. Following the success of this therapy for movement disorders, so DBS surgery has applied to the management of refractory psychiatric disorders and was approved by the FDA for obsessive compulsive disorders in 2009. But the DBS has been used for a lot of neural disease, but mostly used for Parkinson's disease, tremor, and dystonia. I'd like to show the target for each disease. And the first in the case is Parkinson's disease, STN, GPI, VIM, and PPN are chosen as target. In the case with tremor, the VIM is chosen as target. In the case with dystonia, the GPI or VA are chosen as target. Now, I would like the suggested criteria for the surgical eligibility for Parkinson's disease. The high level of certainty about the diagnosis of idiopathic Parkinson's disease, and the clinical progression for a minimum of 4 years. Confirmation of levodopa responsiveness using levodopa challenge test. So we need improvement of at least 30 to 40% in part 3 of UPDRS. Exception to the need for levodopa responsiveness include patients with a severe disabling resting tremor or resistant to the dopamine therapy. The disabling motor complications of levodopa therapy, including the dyskinesia or motor fluctuations. The clinical evaluation should be performed in a specialized multidisciplinary movement disorder team. The functional disability must be defined by scale, Schwab England Functional Scale or PDQ-39. The following attributes give support to the surgical eligibility. The young age onset, severe tremor, needed to reduce medications, nocturnal akinesia. I would like to show the typical indication of the patient of the video tape. The patient left side is on stage and the right side is off stage. So you can see the right side is on stage, the patient can walk independently. At the right side of stage, patient cannot walk. She needs the assistance. You can see the tremor and hesitation of gait and masked face. She has the disability in the daily life. The next I'd like to show the dyskinesia. The drug-induced dyskinesia is L-dopa therapy has the side effect. You can see the dyskinesia on foot. And also you can see the dyskinesia on her head. The next is the severe disabling resting tremor resistant to the dopamine therapy. Yeah, this patient already has undergone the ST and DBS therapy. Now I turned off. The patient shows quickly the tremor you can see. Once more, I turned off the IPG. The patient showed the resting tremor, severe resting tremor, even in he has Parkinson's disease. The suggested absolute criteria for the ineligibility, the unstable clinical comorbidities, major psychiatric or neurobehavioral disorders, definitive dementia, doubtful diagnosis of Parkinson's disease, significant ventricular enlargement or cerebral atrophy in MRI, severe axial symptoms resistant to treatment with levodopa, inability to provide informed consent, social or geographic difficulties in gaining access to the center for follow-up visits and programming of the stimulator, absence of functional disability, and inadequate or fragile social support. Suggested mandatory procedure regarding the candidacy for surgery. It includes levodopa challenge test and brain MRI, and the neuropsychological and psychiatric preoperative assessment. And also the dopamine transporter scan, so-called DAT scan, might be necessary to define the Parkinson's disease diagnosis. So DBS can improve the motor fluctuations. You can see the vertical axis is ADL. So you can see the motor fluctuations on stage and off stage. So the DBS can improve the raw activity of daily life. We can expect the DBS continue to the on-stage of a patient. If medication dose is reduced, the high activity on stage might be worsened, and then DBS can enhance the low activity of daily life. So dystonia. So dystonia is classified based on types and causes. The type of classification include focal, segmental, multifocal, and generalized. The causes of classification includes primary or secondary. So especially the primary genetic dystonia is a very good candidate for DBS. So primary dystonia and DBS, the medical treatment does not always produce the adequate symptom. The terms and the GPI is targeted and both therapeutic response is favorable, but generally accepted target is GPI. The result of DBS for secondary dystonia has been mixed. The response of segmental dystonia, including Maze syndrome and cervical dystonia, has been mixed, and GPI DBS might be effective. I'd like to show the severe truncal dystonia. This patient has a genetic, the DYT6 and 11 dystonia. This is a preoperative video. She cannot stand up, she cannot sit down, and she can't eat. Now we did the GPI DBS. This videotape was recorded soon after the operations. So her symptom is improved very much. She is on the chairs. Now, after several years later, so she can walk and she can eat, she can do everything. The secondary dystonia, the post-traumatic, the post-anoxic dystonia, post-anoxic, the dystonia plus syndromes, and tardive dystonia had been reported in small sizes or case report with a favorable result. The classification of dystonia, the generalized or segmental, so you can see this videotape is the so-called Maze syndrome. I did the GPI DBS for this patient, and I had to get the very good result outcome. So GPI DBS might be effective. The essential tremor. The tremor is classified. Tremor is classified in the resting and the actual and the postural and intentional. So essential tremor is many patients have a family history. It most frequently affects the hands, but it can also involve the head, the voice tongue, and the lower extremities. The prevalence of essential tremor increases with age. The VIM is the most widely agreed on target. Most series report the 70% to 90% tremor control in patients undergoing the traumatic DBS. Tramotabine has been replaced by traumatic DBS. So STN, zona insert, or the preluminoscal radiation may be a more effective possible target. I'd like to show the videotape. So this patient has also undergone the VIM DBS. So now I turned off the IPG battery. This patient shows the typical essential tremor, action tremor. I asked this patient to write his name or draw a line, but he could not. Now I asked the patient to hold a cup. He tried to hold a cup, but he cannot. This is a typical essential tremor. Now I turned on IPG battery. So VIM DBS can completely improve his tremor. You can see the patient can hold a cup and the patient can drink. And also patient can write a letter. Yeah. I'd like to talk about surgical procedures. The surgical procedure, the DBS surgery, consists of 3 steps. The first of all, placement of electrode into the brain. This step is basically awake surgery. The next, the implantation of IPG. This step is a sleep surgery. So finally, attachment of the lead and generator via a thin insulated wire known as an extension. So stereotactic procedure in awake. The first step is that the head frame is fixed to patient head. The second step, the MRI or CT is taken with fiduciary marker for pre-surgical planning. The bar hole is set and the microelectrode recording is done and the test stimulation is applied. The first surgery is the most important one. The state-of-art surgery for stereotactic brain surgery. The placement of electrode into the brain needs these techniques, these technologies. The first I'd like to talk about the targeting. So we have 2 ways, the direct targeting and indirect direct targeting and also indirect targeting. So indirect targeting is based on a standardized stereotactic atlas and on a formula-derived method based on AC and PC landmarks. The formula uses the mid-commissural point, MCP, or the PC reference, which is calculated after selecting the AC and PC coordinates. The typical initial anatomical coordination for the STN are shown in the table. The targeting was then adjusted based on indirect targeting from the border of the red nucleus. This slide shows the indirect targeting based on ACPC line summarized. The target, in the case of Parkinson's disease, targeted the STN and the GPI. So we calculate based on ACPC line these parameters like this. The VRM is like this, 50 millimeter lateral, 5 mm anterior to PC, and just on ACPC line. So if the CT is used for pre-surgical planning and manually, So you can determine the AC PC line. And in the case with the VIM DBS, so target is lateral, the 15 to 18 millimeters, and 6 millimeter anterior to PC, and just on HPC line. We determine the target like this. If you use Lexel frame, they have the X and Y axis from 40 to 160. The target is plotted and calculated by X and Y axis. For example, X axis coordination is 87 and Y axis coordination is 105. So recently, the direct targeting of the STN based on high field MRI is developing. The red nucleus can also be clearly seen, and the STN lies anterior and lateral to the red nucleus. The anterior border of the red nucleus can be used as a landmark for the anterior posterior localization of STN target. And if you have the workstation or the navigations, I mean the FrameLink workstation provided by Medtronic can shoot 2 or more different images. Identify the nucleus in MRI image and create a target. Then create an entry on the surface of the brain, avoiding the sulcus, ventricles, and vessels, and connect the entry and the target and draw trajectory. So like this. To get the target coordination in millimeters and the angle parameter in degree, just click the icon. You can see each coordination and the ring and the angles. It's very simple. The Lexel Stereotactic system is the preferred system for very precise intracranial neurosurgeries. The system uses X, Y, Z coordinate to stereotactically localize any point in 3D space. The arc employs the center of arc principle for encompassing the surgical target in 3 dimensions, enabling full access to any intracranial area. Now, we usually do the microelectrode recording to confirm the precise or functional area. This is our homemade micro recording system. So this system includes the display and the amplifier, and some audio speaker, because we clarify the differentiate to the unit, I mean the basal ganglia or terms or something. This is also our originally developed the 3D atlas. So you can see the subthalamic nucleus and the reticular nucleus and the VA thalamus, VP thalamus. This is a VI. It is very important targeting for the tremor. And the coordinate nucleus, so you can see the GPI. So this is a data sheet. We write down any neurophysiological sign, neural recording, and this is a graph paper. Now we prepare to start the micro recording. I mounted the Lexel frame, the micro drive to the Lexel frame, and we use the motorized micro drive. This drive advanced in the 1 micrometer. This is the microelectrode. Now I inserted the brain and filled the fibrin glue to prevent the CSF leakage. So now we check the impedance, the measurement of the microelectrode. We carefully advance, and if we obtain the unit recording, so I write down each unit and its characteristic firing. For example, so we advance the 16.5 millimeters, that we can get the background of recording activated. Now we enter the coded nucleus. So this unit is typical, the firing of the coded nucleus. And now we get the tramic unit recording. This is a recording, the reticular nucleus. Now we enter the zona insert of the shell of STM. You can hear, well, you can see the high activated of the neural activity. Now we get the STM activity. So like this, we can confirm we can get the good target in the STN by the microelectrode record. In the STN microelectrode recording, so electroactivity clearly increase in the STN when electrode passed on out the STN and enter into the SNR, the neural activity become regular. In the GPI recording, the striatal activity is recorded, and it has low 1 and 10 Hertz spontaneous discharge. Now we enter the GP neurons have a spontaneous discharge rate of the 30 to 60 Hertz, which occur in the bursting or poser pattern. So if we get in the GPI neuron discharge are faster with the rate of 60 and to 100 Hertz. So optic tract can be identified by light sense, which increase the recording background. So in the procedures, so before starting operations, X-rays taken with fiducial marker this X-ray, and X-ray is taken after DBS implantations. So to verify the tip of the implanted electrodes anatomically, so we overlay each X-ray field. So like this. In the case is a tremor, so we can easily verify the effect of DBS clinically. I mean, the test stimulation can quickly stop tremor. It is very relief for us. This videotapes also in the case is a tremor. So before operation, we can check how is his tremor. In the case is the tremor, the target is a VIM. So the first record in the retinal nucleus. Now we get the VIM activity. And also it is very important to clarify the somatotropy of VIM. Somatotropy means where is hand movement related cells or oral or elbow or foot movement related cells. It is important to clarify these motor related cells to completely reduce or improve the tremor. And we can get the tremor related cells. You can hear the background is responding to his tremor. The patient is awake. We can test the test stimulation improve or not. So after microelectrode recording, so the microelectrode recording is two trajectory. So this is you can see that this is a VIM. We implanted the DBS lead, the second trajectory. So the second trajectory. You can see the contact 0, 1, 2 is in the VIM. Now in the case is a tremor, the test stimulation quickly improve is tremor. I mean, confirm the clinically. We can ask to draw a line. He can successfully write his name. Not. The DB therapy requires brain surgery. Risks of brain surgery may include serious complications such as coma, bleeding inside the brain, stroke, seizures, and infections. So once implanted, the system may become infected. Parts may wear through the skin, and lead or lead extension connector may move. So finally, I'd like to talk about outcome of DBS. The Parkinson's disease. So this slide shows the effect of DBS compared with the medications. So this symptom in the cardinal symptom of the Parkinson's disease: rigidity, bradykinesia, tremor, gait and posture disability, dyskinesia of time. So you can see the effect of DBS compared with the medication, that the similar improvement, the rigidity, bradykinesia, tremor. but much better against gait posture, the dyskinesia, and off-time length. The dystonia. So dystonia is usually the refractory to the medications. The generalized dystonia is a very good candidate for the GPI DBS. Left-sided video shows the pre-operations. Right-sided is the post-operations. The patient, preoperatively, patient cannot stand up straightly. So the post-operations, she can walk straight and turned out like this. So this slide shows you can see the DYT1 genetic dystonia has a great effect so compared with the other type of dystonia. So how about the tremor? So DBS has improved effect against tremor. However, the effect might come to decrease for a long time because the pre-surgical 6 months after surgery at last follow-up. So this is the horizontal axis is the follow-up years, and the right side the tremor score. You can see the improvement effect is getting worse in 10 years. So DBS might have habituations. Okay. Now that brings me to the end of my presentation. Thank you for your attention.
Thank you. Thank you very much, Professor Kajita. You may please stop your screen sharing and turn on your video now. Miss, turn on your video.
Okay.
So we can see. Yeah, there you are. Thank you really, Professor Kajita. It was really a very wonderful presentation. You have demonstrated.
I'm sorry, I'm not good at speaking English. I'm so worried.
No, that's okay. Your English was perfect.
Yeah.
Your English was perfect. We really thank you for coming down to our level and teaching us how good is DBS for movement disorders. Since the last time we had the trial session, you had added on several slides. I was really surprised. I really thank you for teaching us elaborately for on DBS on movement disorders. There are so many questions which the young neurosurgeons would like to interact with you. So I would call upon as in the order, Dr. Christian. Are you there? Christian Watt, are you there?
Yes, I'm here.
Yeah, please ask your question, Dr. Christian Watt.
Yeah, I have one question. Professor, how about lesioning for Parkinson disease? Because in developing country like my country in Indonesia, DBS is very expensive. So how about lesioning for Parkinson disease? How about you? Thank you, Professor.
So you mean how is it different between the races and the yellow or white or something?
Christian is asking that DBS is very expensive in his country. So
Yeah,
he's asking about what is the quality after lesioning.
Yes, that's my question.
Okay. Yeah, I think, of course, the DBS is a very expensive one. But the DBS has the adjustable, not something very good advantage. So lesioning is the very cheap one. But if you can make the very good region, it is a very nice one. But if you fail to the good region, appropriate region, I'm so worried about the post-operative side effect, something. I mean the dysarthria or some paralysis or something. So I think so if you start the reasoning of the stereotactic reasonings, I think I think that you have a good training for the stereotactic surgery. Yeah.
Yeah, thank you. Dr. Christian Watt, you want to come in?
Yes.
Okay.
Yeah, please, Dr. Christian Watt.
No. It's very clear statement for the professor. Thank you, professor.
Yeah. Yes, Dr. Watt, please come in.
Yeah, we have. Do you hear me clearly?
Yeah, we can. Please go ahead with your question.
Okay. Question is, what is the best time to consider DBS for Parkinson patient? When do you decide to consider DBS? You start with medication and then you go on, and at a certain point you decide to go for surgery. So what is your approach?
Yeah, thank you very honest questions. So usually in the cases of Parkinson's disease, the levodopa started, and maybe the 7 or 8 years later, the patient will have the motor complications, including the motor fluctuation and dyskinesia or something. Maybe the neurologist will try to some adjustment of the medications, try to improve the complications, but at that time, I mean when the motor complication began in the patient, I think I'm recommend to the indication of the DBS because I started the DBS surgery since 2000. I mean the first the patient already have a 20 years history following the DBS. Unfortunately, the patient with the Parkinson's disease, so finally come to the dementia or a psychiatric problem. Then I think if possible, the patient had the DBS surgery at early stage, so patient get the beneficial effect for a long time. So my answer is the timing is to begin to have motor complication. The patient has motor complication. It is the best time to introduce.
Thank you, Professor.
Yeah.
Yes, Dr. Jitin wants to come in. Dr. Jitin, are you there? Would you like to ask Professor Kajita?
Yeah, yes. Thank you.
Please, Dr. Jitin.
Yeah, I was talking about this adaptive DBS stimulation, actually. So those things were those two things you're talking about. Those things pretty far in the last 2-3 years. Is any development happening in that area?
Professor Dr. Jitin is asking about adaptive deep brain stimulation. Do you have any experience? Adaptive deep brain stimulation.
Adaptive
deep brain stimulation.
Closed circle.
Dr. Jitin, would you like to clarify?
This is something the feedback. A DBS with the feedback.
Yeah. He's asking about the DBS with the feedback.
Yeah. I know. You mean the closed loop DBS surgery? In the future, some company will develop the adaptive DBS system. It's a very nice one because the DBS system sensing the abnormal, the neural firing, and just on that time, the simulation is applied to the patient. It is correct, my answer. So your question is the adaptive means a closed loop DBS system devices.
Exactly. Closed loop DBS. Yes, sir. Yes,
Yeah, that, yeah.
Yeah, maybe some years later, or maybe.
Currently, is it used in Japan?
No.
Not used in Japan. Right.
Not available. Yeah,
Right.
commercially
Thank you.
available.
Thank you. Thank you, Jitin, for asking. Dr. Ahmed Najjar. Dr. Ahmed Najjar, would you like to come in? Dr. Ahmed Najjar, are you there?
Yes.
Yes, please ask your question.
Basically, thank you very much, Doctor, for the nice presentation. A few tips about the DBS. So I was having basically two questions. I think I've heard that you said that in your series that gait improved after thalamic DBS. Am I right? I thought always that the gait is a trait that it might actually get worse after DBS for Parkinson's disease. And what do you think about that?
So you mean the target is a VIM?
No, Dr. Najjar is asking that what about gait instability following DBS? Have you any experience regarding patients developing gait instability after DBS?
Sorry, I can understand. I think your question is a very good point, because the DBS system or improve the tremor or rigidity is a very good improvement. But unfortunately, the gait disturbance is also improved by DBS surgery, but not so long term. Maybe 1 or 2 years later, some patient has the getting worse of the gait. Yeah, that's
it
right.
is there.
Right.
So it's rare, right? Is there any more questions? My co-host Liu, would you like to come in? And all the other members of the ACNS Education Committee, Sachin, Binoy, are you there? Divya is here. Are you there? Would you like to come in?
Prof, thanks for the very nice presentation. I just wanted to know, because of the long-term and the effectiveness of DBS, we depleted if patient on a long-term medication previously, and we tend to start DBS earlier, as you commented much more earlier. I just wanted to know, based on patients who have a DBS implanted, the effectiveness, does it change just like medication? I mean, the effectiveness to control the symptom, is it better? I mean, in long run?
Yeah, I think the basically, so the DBS can improve the levodopa medication responsive symptom. Therefore, maybe the patient with the Parkinson's disease has a long history or disease progressions. Maybe the dopamine responsiveness is decreasing. Therefore, I think the L-DOPA medication has a limit to improve the symptom of the Parkinson's disease. I think the DBS has also the same problem. Therefore, I think my patient has a long term following the DBS surgery. The patient, in such a patient, the medication, L-DOPA therapy, DBS, the both does not help the improvement of symptom. Maybe the patient is unfortunately bed rest. Yeah, maybe in the near future, yeah, some treatment will the necessary.
Thank you, Professor. So if there are no more further questions, we would wind up this session. Once again, I would like to thank Professor Kajita on behalf of the ACNS Education Committee, as well as my co-host Liu and the president of the ACNS, Professor Yoko Kato. Thank you very much for giving us a detailed description of the procedure as well as the effectiveness of the brain stimulation in movement disorders. Thank you very much, Professor. And I hope we would like to have your association in the future also regarding other lectures on the ACNS webinars. Once again, thank you. Thank you very much. John, thank you, John, for organizing this. And thanks all my colleagues of the ACNS Education Committee for taking part here. Thank you. And for the next Saturday, I would like to announce the webinar of Professor Naoki Otani. He is going to talk about extradural temporopolar approach for paracellular lesions. I invite you all to join our next webinar on Saturday. This is the same time, 6 p.m. Indian Standard Time and Japanese time, 9:30 p.m. So thank you all. Thank you once again. John, you can take over. Bye-bye.
Okay.
Bye, everyone.
Thank you, Doctor. Your English is better than our Japanese.
Thank you so much.
So thank you. We understood everything. And welcome, everyone. Great job, Rasha. And we'll see you
Thanks,
everyone next week.
Yeah, sure. See you all next week.
Thank you,
Arigato,
Professor.
arigato, arigato, Professor.